Hello, everybody. Thanks for the International League Against Epilepsy, which is represented by Chauvin, for organizing this lecture, which will be done by Dr. Hayder Hassoun from Iraq. And the topic would be about the epilepsy care in the era of COVID-19. I'm happy to introduce Dr. Hayder for taking this session, and there will be questions and answers at the end of the lecture. The lecture, it would be around 35 minutes and followed up by questions and answers from the audience. Dr. Hayder, can you put your video on? Hello. Yes. Hello, Dr. Hayder.
Hello, Dr. Majid. Yes, I think the video already recorded by Chauvin.
Right.
Yes,
I've already introduced you for the audience. Where were you with me? Did you hear my introduction or?
Yes, I hear it.
Yes. Okay, so the session is yours. You can start, Hayder, your lecture. Thank you very much.
Yes, thank you.
Thank you, Chauvin.
Bismillah ar-Rahman ar-Rahim. Dear colleagues, ladies and gentlemen, Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening. Bonsoir. Masa al-Khair. I am Professor Hayder K Hassoun from Najaf city, Iraq, which is about 160 kilometers southwest of the capital, Baghdad. I am faculty in medicine, Kufa University. Really, I'm very happy and my pleasure to be with you in this educational program. And I would like first to thank ILAE to invite me to be part of educational program in the epilepsy program, teaching and educational programs. Really, you know that COVID-19 really changed all the world, specifically speaking, our social and medical life. And in our daily practice in neurology, we adopt many guidelines to deal with the patients, not only in neurology, but in different branches of medicine. The idea is that all the things have the same target. It is very important to keep your patient safe, the care provider safe, as well as with optimal control. Today, we are talking about the management of epilepsy in the COVID-19 infection era, which is really a challenging and important topics. We try to achieve our objective, this 30-minute talk, and we hope that all attendants will get benefit from that. This is my disclosures. First things I would like to mention, a very famous philosophical statement mentioned by Professor William Oster, which is a very famous physician, that humanity has three great enemies, in fact, fever, famine, and war. Among them, the fever was the most terrible things. And this is what we observed in our daily practice in real life. The first COVID-19 infection in our country, specifically in our region, reported in Najaf city. And after that, more than 100 confirmed cases are reported. And local authorities at that time start curfew on March 17 to limit the spread of disease. Really, now we are living in very severe crisis of COVID-19 infection. Last month, we report in our city 9,640 cases, And if you compare that with the previous year, there was a very minimal cases reported in February last year. And you can see the cases step by step increased. But to such crisis which happened in the last month, we didn't notice in the last year. Our objective, we try to achieve our objective today. We have small notes about introduction to the topic. We will mention some what is the association between epilepsy and COVID-19, how it is important to maintain seizure control and keep your patient safe, but last but not the least is instructions for caregiver. This is very important questions we have to answer. Always the patients ask, does my epilepsy put me at a higher risk of development of COVID-19? Before answering this question, it's very important to take idea about the pathology and pathogenesis of this wild virus. And of course, the experience started from as you know, in the MERS 2005, and the previous experience coming from SARS1 in 2002 from China. The SARS-2, in fact, have peculiar phenomena and peculiar features that it has two parts of the elements in the virus, spike protein and viral RNA. The theoretical aspects as well as practical and data evidence-based medicine show that this virus have tendency for receptor, ACE receptors type 2, or it is directly invade the mucous membrane of respiratory tract to enter inside the cells. This is in the day 0, day 1, and 2, when the virus start to replicate or targeting immediately the host ribosomes. There will be genomic RNA replication, translation with production of multiple proteins that lead to initiation of different pathways in subsequent days. We have a stimulation of direct activation of lectin pathways, immune complex classical pathways, which is the C3 and C5, or toll-like receptors alternative pathway. Of course, this is a start with viral entry, virus replication in the airway, and then start to have immune reactions with the production of multiple cytokines and interleukins. There will be a release of this substance causing more accumulation of neutrophil and monocyte and macrophage, and then the end result is destruction of air cells. Of course, this is happened day after day, and when the patient reaches day 5 to 7, there will be activation of innate immunity in the lung, maladaptive inflammatory response, and the second week, the patient may pass into stage of ARDS, in which the ventilator and the respiratory impairment will happen, and the mortality may happen in this week already. Understanding of this pathogenesis will understand how we can approach in the management of these patients with COVID-19 infection. We start with ACE inhibitors, and this is many evidence-based medicine that show effectiveness of this medication earlier in the course of the disease. Then use of antiviral like remdesivir and ritonavir and lopinavir in the day 2 and day 3 when the patients have still in the mild to moderate cases. If the patient passes into severe stages, then anti-C3, anti-C5, anti-interleukin 6 and 1, and even tumor necrosis factor antagonist may be used. So this diagram shows you that the patient may pick up in the asymptomatic phase, and the biomarker here is lymphopenia. And when it becomes mild to moderate, lymphopenia is increased. There will be increase in the PT, ferritin level increased mildly. D-dimer also is elevated, LDH, and mild hypoxia. When the patient passes into severe stage that necessitates hospital admissions, there will be more inflammatory marker increment, include D-dimer more elevated, ferritin elevated. There will be abnormal blood gases and increase in the troponin and reduction of platelet count. At the end stage of the disease, when the patients need intensive care, there will be more what is called cytokine storms, which may be associated even with organic failure. So the good news about the virus is not nootropic at all. Yes, we have reported cases of acute necrotizing hemorrhagic encephalitis and death. And some report mentioned that we have isolation of the virus from the parent, but this is very doubtful. because it is not reported elsewhere. We have many articles coming from OHAN, and this is from American Academy of Neurology, showing that the nervous system can be involved in 1/3 of the cases, and maybe 50 in severe cases. This include the dizziness, headache, impairment consciousness, acute cerebrovascular disease, ataxia, seizures. Peripheral nervous system have a part of involvement, include the taste, smell, and vision, nerve pain, and skeletal muscle pain. The patient presentation may come with acute neurological complication, and include viral meningitis, anosmia, encephalitis, post-infection and disseminated encephalitis idem, and post-infection brainstem encephalitis Guillain-Barré, which is widely reported. More cases have been reported, and myositis and acute necrotizing hemorrhagic encephalitis. We reported 2 cases reported in American Journal of Case Report. Subdural hematoma can be associated with the COVID-19 infection, and we have also a myelopathy, certain type of myelopathy. We try to answer that, is my epilepsy I'm at high risk of COVID-19 more than the other people? The CDC, the Center of Disease Control and Prevention, suggests that neurological comorbidities, including epilepsy, may be at a risk factor for COVID-19, despite lack of evidence. But the experience from the previous viral pandemic that happened in 2005 by MERS and 2002 from SARS1 did not show any direct association between the infection and the liability of epileptic patients to have a severe infection of COVID-19 infection. What are the factors in epileptic may increase the problem from COVID-19? In fact, per se, the epilepsy itself not a risk factor for having a severe infection, unless it is associated with other health problems. This is very important fact, should be kept in mind. So always reassure your patient that you are not likely to have more problem with COVID-19 if you have the infection, except if you have comorbidities like, for example, smoking, obesity, diabetes, heart, lung problem, cancer, and immunological disorder. Other neurological disorder which might induce or causing epilepsy, again, it may render the patients likely to have more severe infection, like, for example, a patient with swallowing difficulties or respiratory problem. And of course, a medication, some of the epileptic patients having a medication like ACTH, steroids, everolimus, and immunotherapies like IV immunoglobulin and rituximab. Of course, these may cause suppression of immunity and make the patients with epilepsy likely to have more severe infection. However, most anti-epileptic drugs do not affect the immune system. Again, if you review the literature, we have many reported articles studied the association between the epilepsy and immune system. The immunological abnormalities have been reported in epilepsy, either by direct effect of epilepsy on the immune system or by the effect of anti-seizure drugs, anti-epileptic drug on serum immunoglobulin. There are several reports concerning the effect of anti-epileptic therapy on the immune system, and they found that there will be a decrease in the level of immunoglobulin, especially immunoglobulin A and G. And not only this, this may affect both humoral and cellular immunity. But this affection, not to extent that make the patients liable to have a severe infection. And this is an article coming from the neighboring country, from Iran. They have a cohort control study of the epileptic patients versus control, and they found that they measure the immunoglobulin A, immunoglobulin G, and immunoglobulin M level in a cohort of epileptic patients, and they found that there is decrease in the level of immunoglobulin A and G, specifically among patients receiving carbamazepine. This is of more concern. Also, a similar report have been reported with phenytoin and sodium valproate. Again, this is not to extent that make the patients liable for severe COVID-19 infection. The immune system is affected by humoral and cellular immunity in conclusion of this article. either by direct effect of epilepsy and or by anti-seizure drugs. Again, I would like to stress very important point. This is not to extent that make the patients liable for severe infection. So the COVID-19 patients, and he's already epileptic, the seizure is likely to be triggered in this patient. Why? Because of fever, one of triggering factors for epilepsy, sleep deprivation because of overnight cough, hypoxia in severe end stages, sometimes a manifestation of neurological complication, for example, encephalitis and encephalopathy. The drug interaction, again, is very important. And here I would like to add very important point. We have hundreds of cases of COVID-19, they pass into a severe state, and they are, whether they are epileptic or multiple sclerosis or CVA or whatever, because of stress. The stress is very important that may trigger the seizure in patients with COVID-19 infection, and he's already epileptic. So considering of these factors is very important to maintain optimal control of seizure, which is our target in the management of patients with epilepsy in COVID-19 era. A big detail suggests that central nervous system could be a potential target. This is a theoretical aspects of the point of the fact that SARS-CoV may target the CNS. And as I mentioned in the previous slide, all the database evidence we have in the literature that this virus is not neotropic one. Yes, we have reported cases of Sars1 Encephalitis, which isolated. We have reported cases of Sars1, not Sars2, with the affecting MS patient and have been isolated from CSF. But these are scattered. We cannot rely on it 100%. So the virus is not a neurotropic viruses, and this is very good news. But the CNS can be affected indirectly by fever, cytokines productions, by immune-mediated. This is why the patients with COVID-19 develop IDEM, encephalopathies, and Guillain-Barré and myelitis. Febrile convulsion and Dravet syndrome are likely to have more seizure if they develop infection because, of course, of the fever and the infection, and need to be closely monitored. Infection or viral infection disease might increase the risk of SUDEP. Still, we have no data about this, but one should keep this in mind always. This is very busy slide, but it's a really important slide showing in this column, different types of the anti-epileptic medications, and this is different type of the anti-COVID-19 infection medications. We have different type of lopinavir, ritonavir, remdesivir, chloroquine, hydrochloroquine, and nitazoxamide, and ribavirin, tocilizumab, interferon beta 1A, and oseltamivir. All these medications nowadays used widely over the world in the COVID-19. And when you are dealing with epileptic patient receiving one or more of these medication, it's very important to know something about the drug interaction. Some of the drugs need to be doubled. Some of the drug need to be reduced, while the majority of the drug, there is no need for the adjustment if the drug interaction is minimal. So this color, nearly red color, drug should not be co-administered at all because of a lot of drug interaction. This includes in this category phenytoin, phenobarbital, and carbamazepine, while more pinkish color, there is potential interaction and may require dose adjustment. Include cannabinoid, clonazepam, clobazam, diazepam, ethosuximide, felbamate, and gabapentin, while many drugs have no or minimal drug interaction. And this is very beautiful to be given, like, for example, lamotrigine, lorazepam, piracetam, and of course, I don't forget the viagabatrin. All these in the turquoise colors have no drug interaction. So we classify, this is, I think, is difficult to be kept all this information in mind, but I suggest to make a copy of this poster and put it in the epilepsy outpatient clinic to know clearly the drug interaction to avoid any increase in the seizures that may increase even the mortality from COVID-19, because of malnutrition, immunological aspects, as well as anoxia. Further anoxia will have patient will have because of the seizure. So optimal control of the seizure is very important. And without this knowledge about the drug interaction, you cannot achieve this target. So we can classify drug interaction potential as non-significant drug interaction, which is very beautiful in levetiracetam, praguiracetam, pregabalin, vigabatrin, and gabapentin, while mild to moderate potential drug interaction include in the carbamazepine, acetate, oxocarbazepine, lacosamide, lamotrigine, clobazam, and perampanel, periphenamide, tagabine, topiramate, and zonisamide. Significant drug interaction which need to be avoided as much as we can in cases of phenobarbital, phenytoin, carbamazepine, primidone, cannabinoid, and cenobamate, and valproate. The important point should be kept in mind in using of Vimpate, lacosamide, carbamazepine, and felbamate can cause a QT or PR prolongation. Lacosamide should be used with caution in patients with the cardiac conduction defect, like AV block and sick sinus syndrome without pacemaker. Also sodium channelopathies like Brugada syndrome, concomitant medication. The patient with Brugado, concomitant medication like, for example, chloroquine and ondansetron, these really should be carefully monitored for the cardiac function. It's very important because the patients might develop bradycardia or arrhythmia or AV block, and you need to assess the cardiac function carefully and follow closely to avoid any cardiac complication or further morbidity or mortality because of the COVID-19 infection. So the ECG before beginning lacosamide and after titration to a steady level is very important. Lacosamide may induce atrial fibrillation, flutter or fibrillation, especially in those with diabetic neuropathy and cardiovascular disease. Cytochrome P450 enzyme in the liver are downregulated by infection and inflammation stimuli, including the COVID-19 infection, of course, included one of the infection that caused downregulation of this enzyme. But using of interleukin 6 antagonist inhibitor like tocilizumab may restore the function of CYP450 enzyme activity, leading to increase in the metabolism of drugs that are CYP450 substrate, include phenytoin and carbamazepine and lacosamide and perampanel and phenobarbital. In this case, you don't need to increase the dose of this medication, but vice versa. You have to assess and monitor the drug level carefully if the patient is stable. If not, you can shift the patient to IV induction, IV medications. I will mention that in next slide, inshallah. Lopinavir and ritonavir decreases the plasma concentration of lamotrigine, and in this case, you need to double the dose of the lamotrigine when you are using lamotrigine in epileptic patient with COVID-19. He is on lopinavir or the ritonavir. Hepatic enzyme inducer like Tigritor, carbamazepine, phenobarbital, phenytoin may decrease remdesivir efficacy, which is widely used in our region as well as the world. Currently, there is neither experimental, this is very important, nor clinical evidence for any direct interaction between favipiravir and oseltamivir with anti-epileptic, and this is very good news. This is why this is widely used in epileptic patients as anti-COVID-19 infection, because there is no experimental, no clinical evidence of any direct interaction. If we are dealing with the first seizure, if, for example, in the COVID-19 and the patient is coming to outpatient with first seizures, in this case, very smooth, swift assessment as in usual situation to assess the risk and underlying pathology is very important. But you try to use what's called telemedicine if it is adequate for you. We try it in most of the cases to avoid the attendant of the patients to the hospital. And the first seizure patient should have a brain imaging, CT scan, preferred acutely, often non-enhanced, but MRI should not be done unless the patients have high probability of serious lesion. ECG should be requested to differentiate between syncope and versus seizures. At the same time, you assess QT interval for any evidence of arrhythmia. History of sudden death and cardiac death should be recorded and reported. EEG is essential sometimes in the COVID-19 when it is feasible to classify the epilepsy, choice of medication, and prognostication, and sometimes for the purposes of license, of driver license and vehicle license agency. Hydroxychloroquine may lower the seizure threshold. Initially in the pandemic, in the last year, we are widely using hydrochloroquine, as azithromycin, and they found this may cause a prolonged PR interval and QT interval, and nowadays it's very of limited use. When patients with epilepsy become ill with COVID, there are two possible scenarios. For example, if we are in the outpatients and the patients reported a symptom of COVID-19, and you have to assess the severity of COVID-19, whether it's mild, moderate, or severe. Anyhow, we have two scenarios. The first scenario, which is 2/3 of the patients have well-controlled on stable dose of anti-epileptic, while patients have drug-resistant seizure, which is 1/3 of them. The first scenario, as long as the patient is stable, mild to moderate infection, and even in severe infection, and the seizure is not happening, please do not change the anti-epileptic medications. The treating physician should be aware of any potential drug interaction that mentioned in the previous slide, adverse effect and complication, close monitoring of the patient to ensure efficacy and limit toxicity of therapeutic intervention, as well as therapeutic drug monitoring may be indicated and necessary in majority of the cases to assess the level, and accordingly you can adjust your dose. Action to minimize cardiovascular risk, again, in the first scenario is very important, including ECG, to assess QT interval, correction of electrolyte imbalance, which is very important after administration of drugs. Serum potassium, keep it to the level of more or less 4.5 milliequivalent, and serum magnesium more or less more than 2.2 milligram per deciliter. Avoid the drugs that might cause arrhythmia or prolonged QT prolongation, like, for example, ondansetron, proton pump inhibitors for acid suppression. This is why we use most of the cases famotidine, and some of anesthetic agents, of course. ECG signs of impending torsades depointase develop. In this case, you have to discontinue the offending drug, administer potassium and magnesium, consider temporary pacing to prevent bradycardia, and long pauses, and transfer the patient to highly specialized center. This is a logical thing. As I mentioned before, the ECG is very important to be done if the patients, for example, develop ectopic or the bigeminy or torsades depointase. In this case, it's very important to keep the electrolyte well, monitor the patients, temporary pacing if the patients have a significant bradycardia and when it is indicated. And in this case, we may have a team of cardiologists, a cardio intervention to share the opinion with the dealing of the patient to maintain optimal control of the seizure as well as the optimal outcome of the COVID-19 infection. Seriously ill patients, that is severe to infection of COVID-19 and he's already on lacosamide, should be monitored carefully for bradycardia, and we mentioned that before, specifically in lacosamide, and treated promptly with isoproterenol or atropine, and if available, external pacing. The second scenario, when the patients have severe infection and resistant epilepsy, in this case, you have to switch several drug medications with little drug interactions. Intravenous use of formulation of the medication is important, and drugs with significant respiratory and cardiac adverse effects should be avoided. For example, lacosamide, levetiracetam, and brivaracetam should be or could be safe treatment options. In levetiracetam, we can use 30 to 60 milligram IV loading dose over 10 minutes, and then 1,000 to 3,000 milligram per day in two divided doses. Doses adjustment according to the renal impairment. Brivaracetam could be administered 25 to 100 milligram twice daily, 50 to 200 milligram per day. Dose adjustment is recommended when we have hepatic impairment. Sometimes the patients develop organic failure, and impending liver and renal function may happen in a critically ill patient with COVID-19. In this case, if the patients have moderate to severe hepatic impairment, the following anti-epileptic may need dose adjustment, like brivaracetam, cannabinoid, carbamazepine, cenobamate, and lacosamide, lamotrigine, and perampanel. The general rule you have is to assess the drug monitor, assess the renal, hepatic, and you adjust your dose to maintain optimal control. It is not a difficult statement. I think all of us know in the daily practice, this is a logical thing. The clinician should monitor serum drug level to guide dosing patients, as I mentioned. The most important other aspects of our objective in this lecture is the importance of maintaining seizure control in COVID-19 crisis, as we are living now in this situation, really indeed. Uncontrolled seizure could cause some problem. Why? Because if the seizure is not controlled, there will be increased mortality. There is increased malnutrition. And this is, of course, will affect the immune system. The patient need to go to emergency. And our target in our daily practice to keep the patients away from the hospitals, because the patients with epilepsy coming to the hospital is likely to have the infection. So as long as you have patients, cooperative, controlled seizures, you are not needing to attend the patients to the hospital. And sometimes the patients develop status epilepticus because of lack of medications, as I said, sleep deprivation, fever, malnutrition, and the patient pass into status epilepticus. In this case, the patient need admission, need ventilator, and because of the ventilator in time of shortage of mechanical ventilator, and this is really over all the world, because you cannot over the hundreds of ventilator in a moment or 1 or 2 days. This has happened in our situation. So as long as you have controlled the epilepsy, you can avoid all these complications indeed. To help control seizure, some societies do not recommend changing the antiepileptic. This is logical. As long as the patient is stable on his antiepileptic, you are not need to change his medication. Inform the patient that they should not discontinue antiepileptic without advice of physician, even if it would affect the immune system. Follow healthy habits, eat, drink, sleep adequately, reassurance, psychological support. All these factors help to control seizures. If the patients, for example, with COVID-19 symptoms and coming to the hospital and he's epileptic, how can I treat? This is depending on severity, of course. The mild to moderate cases can be dealt with in the home or outpatient clinic. Acetaminophen can be used safely, ibuprofen for fever. Most cold medicines are fine. Avoid those with pseudoephedrine and antihistamine. Treat vomiting and diarrhea to keep antiepileptic dosage appropriate. Ensure adequate oxygen, which is very important. Treat infection with the antibacterial and antiviral depending on the indication, severity, level of oxygen, as I mentioned in the previous slides. Keep epileptic patients safe. How can I keep my epileptic safe? It is very important to ensure continuous supply of medication. Even if you are dealing with a drug health care provider, themselves can take medication to the house of the patients. Telemedicine, telephone consultation is effective, and this is really what we did, not only in epilepsy, in MS patients, and CVA, and the patients can record, home video record, and send that to us, and we evaluate the type of, for example, of minimal attack of epilepsy. Minimize investigation. We should not to be investigator in this period because of lack of resources. EEG may be needed to change medication sometime in electrical status or spasm. MRI in treatable pathologies if the patients really deserve to come to the hospital because of the seriousity of the condition or have some neurological deficit, which is new, that need to clarify the underlying pathology. All epilepsy patient and care providers should have an emergency care plan. For example, an emergency unit, we have to have a rescue medication like buccal midazolam, a threshold to attend hospital. Most of generalized tonic-clonic convulsion can be self-limiting and can be treated at home. if there is a crisis and there is limitation in transfer, apoplectic transfer, you have to treat the patients by rescue medicine, so whether it is in the primary health center, in the emergency, or even in the home. Instruction given for care provider, very important. If epileptic patients, for example, having a COVID-19 infection, their caregiver should seek treatment. If caregiver become infected, this is a problem. They should stop providing care to epileptic to avoid the transfer of infection. This is logical. For patients with epilepsy who live alone, it is suggested to keep regular contact with someone to inform that they are all right while self-isolation, especially patient with uncontrolled seizure. This is ABC. Any patients with epilepsy and he's living alone, it is very important to make a psychological support for him. It is very important to tell him that all of us as a team in epilepsy management are with him, and we advise him by telemedicine, telephone, video record. Even if the patient is uncontrolled seizures, we can give him a different advice, for example, to control and make the control of epilepsy or seizure in optimal way. So in the keynote, and very important to keep in mind, make your patients feel supported and know that they have not and will not be forgotten by his physician and the management team. So the healthcare services being focused on the combating the COVID-19 crisis. All of us are fighting against this type of wild infection. Epilepsy per se is not a risk factor for severe COVID-19 infection without presence of comorbidities. Did not change anti-epileptic in patient with COVID-19 as long as he is stable. Monitoring is all what you need to do with dose adjustment. And for the control of seizure, choose anti-epileptic medication with less drug interaction to avoid any dose adjustment. And thank you very much. Really, I'm sorry if I'm bothering you with these slides, a lot of number of slides. I hope that you can get benefit from these slides, and we hope that we can see each other in near future, inshallah, face-to-face contact. And I would like to say goodbye for all, and I am happy to meet you in next Friday, inshallah, live to receive any questions from you. Thank you very much, and bye-bye.
Thank you, Dr. Hayder, for this fascinating and interesting lecture. Especially, it's a new topic for the last 1 year, and definitely there will be a lot of efforts to be done by the health service to support this patients with epilepsy, which need, as you said, probably a telemedicine or a telephone consultation, which will help them to overcome their problems. I will open the chat, the questions and answers for the lecture. I'll be waiting for if there will be any questions. So it is really a very informative and fascinating, really, lecture. I enjoyed it very much, Dr. Hayder.
Thank you very much, Dr. Majid. Thank you. Thank you very much.
I myself, I don't have much really to add for this thing. Any question answers? Probably if the audience have any question answers, they are all welcome to send their questions and answers. It's good to hear that from you, Hayder, that epilepsy alone is not a factor to have a risk factor in COVID-19, unless you have comorbidities like diabetes, hypertension, or other chronic diseases.
Really what we observed in the daily practice, that stress is a major factor, really. I have no data about that, but the patients, as long as he's calm, accepting the infection and dealing with the infection in a positive way, he will pass it definitely. But the stress is really, one of the triggering factor for the seizure is the stress and lack of sleep. One of the patients with epilepsy having COVID-19 infection treated at home, he's not slept well for 3 or 5 days because he's worrying about oxygen saturation, the pulse,
Yes.
and this is, I think, as long as the doctor beside him by telemedicine, by phones, contacts, Facebook, Messenger, whatever, he will we will keep the patients calm until he passes the critical period of 5 to 7 days. I think stress is very important factors.
Did you make any hotline for patients with epilepsy at your center, or?
In fact, we formulate a certain design for the outpatient, because in our center, the outpatients include for example, patient with epilepsy, patient with general neurological problem, patient with MS. What we did is we make a station outside the center, just to see, and they have a special entourage with fully PPE protection for our care provider, our staff. The patients suspected to have something, we have a rapid test available widely to see whether the patient's having infection, old or new, although it is not definitely give you 100%, but as long as we get benefit a lot from this test. In fact, if the patient is symptomatic, we can label him, for example, as a red color. Red color means special protection, special route. He should enter special route. And the better route, we have an emergency unit for the COVID-19 infection patients, and they can deal with it with those patients in that part. The patients with green, that's to say, his enter inside the center to take medications, to educate him that the attendant to the hospital in this period is very critical. You can use, for example, the phones or the phone contacts or telemedicine contacts to avoid, and not coming unless it is necessary to come. And we have to ensure that the patients have received his medications. I think this is the initially done in the last year, and we continue through these days, especially in the last 3 months. We have very severe crisis of COVID-19 infection.
There is a question, Dr. Hayder, from Dr. Shainaz Treki. She's thanking you very much for this lecture. And she's asking, what about the availability of ASM in your countries during this pandemic? I don't know what she means by ASM.
It is anti-seizure medication, I think.
Anti-seizure medications, okay.
I think.
Availability, yes.
Yes, thank you very much for the questions. In fact, we try to concentrate on the parenteral IV medication in emergency unit, because the patients with COVID-19 and epilepsy, the presence of fever will aggravate the cluster of it, and the patient may pass into status. We have to have availability of sodium valproate IV. Unfortunately, levetiracetam IV is not available in our country. We have IV epanutine, we have IV dibakine, and luminal and midazolam. This is a rescue medication should be available in emergency, and even some of the patients who are afraid of coming to the hospital and already epileptic, and the epilepsy over the last 6 months is not well controlled, we ask them to make, for example, buccal midazolam, which is available again. Lorazepam is not available, but instead we use diazepam, and diazepam is very risky sometimes if the patients, for example, have low oxygen saturation and even luminal. So availability of oral medication is good. Majority of oral medication is available, but the IV medication, I think we have a limited number of IV medications. As I mentioned, we have ipamectin, we have dibacane, sodium valproate, and we have IV diazepam and luminal, phenobarbital.
Good. Regarding in my country, unfortunately, the emergency drugs are not available for the last probably 2 years. Usually it's supplied by the government, but unfortunately the situation in Libya is not great, as everybody knows, and the patients, they have to buy the emergency drugs by themselves, unfortunately, from the pharmacy. Currently we have only the rectal diazepam available. The buccal midazolam is not available. It used to be imported by the government, and it was available, but unfortunately for the last 2 years, all our epileptic patients before the COVID-19 and during the last year, during the COVID-19, we don't have buccal midazolam, which is really a pity.
Unfortunately.
Yes. It seems to be there is no questions so far.
Yes, there's a question from Shahnaz. Yes, Shahnaz Sharfi. It's mentioned about, it is not a comment, it is not a question, as I think
were you obliged to change
yes,
to generic names?
Yes, of course. If the brand is not available, you have no other choice. You have to use the generic medicines. I think generic medicine is not always bad, because the cost effectiveness, if you have a good number of patients and receiving, for example, a generic medications, and you see and you can test it practically, it's useful. But I think it's not a problem if you use it really, because this is the only way sometimes available. We have a lot of generic medicines, not only in the epilepsy, but in all branches of medicine. I think the physician should weigh the benefit-risk value and the cost effectiveness before deciding the using of generic medicine, because this is really risky. Why? Because you are dealing with epilepsy. If the medication is not so effective, the patients tend to have seizures, one and more, and there will be more complication and more attendant to the hospital, more cost and more resources being spent on the patients. So I think this is up to physician, up to the situation, and up to the cost that the patients can offer. Because the MOH nowadays, Minister of Health, I think all the area here is not able to provide resources of a brand medicine, not only in Iraq, everywhere, because this is need big budget, and majority of the budget resources now coming toward the COVID-19 infection. If you have another idea, Majid, in your country?
Yes, it's the same actually. Most of patients, we have problems when usually most of the anti-epileptic drugs is controlled and imported by the government, and when they change sometimes the medications name, they imported from other hospitals, from other companies. Immediately there is a rejection by the patients, because they are used to this type of medications, and usually they prefer the original ones, the one which are very effective. But sometimes they are forced to change the medication to another type of companies.
Yes.
We have a question here. What's
from
against valproate, in your opinion, in COVID patients?
Yes, thank you very much, Dr. Rab, for this interesting question. Dibacane is very widely available over all the world. I mentioned in the probably in the middle of the lecture. If the patient is stable, you are not need to change the medication, whatever the medication the patient on. But if the patient is not well controlled, you can think to change or you adjust the dose. Regarding debacking in COVID-19, it's very important to monitor liver function test because, you know, if the patient is having a mild infection, I think there is no problem. But if the patient is having moderate to severe infection, and you know the platelet count is in COVID-19 maybe low, lymphocyte is low, SGOT, SGBT is elevated, and in this case, you have to weigh the benefit-risk ratio. If the SGOT, SGBT is markedly elevated, more than a triple of the normal, in this case, I think you have to either you do drug monitor. If the drug monitor of debacking is very high, you can reduce it. And this is depending on anti-COVID-19 infection medication you are using. Some of the medications, in fact, used for recovery make debacking level is higher than the normal. And in this case, you have to reduce the dose and you follow the patients closely. If the patient's liver enzyme persistently increased, especially in severe infection, in this case, and the dose adjustment is cannot be applied depending on drug monitor, I think you have to change your medication to other safely medication, for example, levetiracetam or pivaracetam, which is not available in our country. We have levetiracetam is widely available. I think in this case, the answer in brief is to monitor the patient liver function is very important. The platelet functions to be monitored carefully in the patients with COVID-19 and debacking use.
Thanks, Hayder. I think we still have time till more 8 minutes. We will be waiting if there will be finish up if no more questions. So if there will be no more questions, we can close the session. And thanks again very much, Dr. Hayder, for this really fascinating and interesting presentation you made on epilepsy and COVID-19. And thanks for the support by Chauvin and the International League Against Epilepsy for supporting us electronically to perform this lecture. If you have any word, Dr. Hayder, to say.
Thank you very much, Dr. Majid. I am very happy to be with you and with our distinguished attendant. And I would like to thank ILAE for the invite me and give me this opportunity to be a part of educational program. I think this is the first step towards more cooperation. And I'm very happy again to meet you and meet Chopin for the this interesting event. Thank you very much.
Thank you very much. Thank you.